Based on my experience in treating patients in Latin America, we can see that the burden of the treatment is one of the main reasons for treatment failure. We know that patients that are needing anything beyond 6 injections a year, that becomes unbearable. It's not only for the system, the relationship with the payers, but for the patients, the families that have to come with the patient to the visits. So this constant need for an injection is the number one burden. I mean, they can face the cost, the family can make an effort, they can drive many hours, but having to sustain injections regularly for most of these patients is the reason number one why they fail the treatment. So if we look at the treatments that are being under investigation now, those that are seeking longer durability are the ones that are going to have the best response and best selection from the patient's point of view. But there are many delivery systems that are being investigated at the moment. Some of them are inserts that are placed inside the eye. Some of them, they use, for example, gene therapy. Some of them use devices that are implanted in the eye and they're refilled in a frequent manner. But basically what we want is something that can last at least for a year. That would be the sweet spot for durability. And we would need this treatment to leave no marks behind. I mean, devices are great, they do work really well, but there's always, something left behind in the eye. The same for, any modification of the cells of the treatment. We will need to see what are the experiences from the patient point of view. But an ideal scenario will be one in which you have something that you can deliver consistently at least once a year, and that will be the perfect fit for the majority of the patients. Of course, we welcome all the developments being made. The more we have, the better, because that expands the menu that we can offer to our patients. But we very often have results coming from clinical trials that they show, quite interesting durability. But many times we try to, translate that to the real world, to the type of patients that will be all comers, not just the selected patients for the study. And we tend to see a difference between the results that we see sometimes in some of the clinical trials and the results that we see in the real world. If we look at the real world data, we can see that over time, majority of patients ended up losing vision, despite whatever treatment they are receiving of the approved treatments that we have today. So we need to push a little bit further forward and have some sort of treatment that can last for 9 to 12 months. A year would be the ideal scenario in which we can see the patients again in between new injections and have total control of the disease. Also, the sense of a pulsatile treatment seems to be something that affects the patients being treated in the response in the retina. The more pulsatile the treatment is, the more fibrosis that we see in this type of patients, and that affects the outcomes of the treatment. So ideally, we would have something that is constant and steady and can maintain the inhibition of VEGF or any other mechanism of action during a long period of time, but in a constant manner. That seems to be the window of opportunity to finally treat patients for the long term and not have any gaps in the results that we have from the clinical trials to the clinical setting. When we compare the results that we get in the treatments within clinical trials in Latin America, they match exactly what we see in Europe or what we see in North America. And that comes to a specific point within the sort of magic of the clinical trial where patients never miss any visits, they attend and they receive the medication constantly, the response is very good. But the real world is completely different in Latin America than what it is in Europe or North America for the case. So we would see that in Latin America, patients have limited access. That having limited access to the medication show that a number of maybe 3 injections a year, that is extremely low. And the results that we see in vision are dramatic. So we need for our patients something that we can give them in a more, spaced fashion. So we can do an injection at least every 6 months. That would be an ideal scenario. In clinical trials, same results. That means the biology is exactly the same. But when we look at those patients in the real world, our treatment is really bad. And that is one of the main reasons why Argentina is such a great recruiter, because patients end up knowing that if they go through the normal system, they will take a good while to get the treatment. And if they take part in a clinical trial, they will be well treated, and they're very interested in being part of a clinical trial. So we offer this option very often to them. I would say that today the biggest gap is durability. Patients can take the injection, not many, but they're happy to take a couple of injections a year. But they have difficulty in coming back for the clinics. Technology is widely available these days.